welcome you all to the 5th edition of the IHRS Cardiology Training Program. So this session happens on the second Sunday of every month, and this is focused on teaching electrophysiology to DM and DNB cardiology students. Every cardiology student in the country should be given this opportunity and this exposure to what is going on in the field of electrophysiology, hence this excellent initiative from the Indian Heart Rhythm Society. We have had 4 excellent editions so far in this year 2025. And this session, pleased to inform that there are 250 registrations around, which is a great number. And I'm happy this program is growing over the time. We have excellent topics lined up, great speakers, and beautiful moderators who can moderate this session. I cannot find anyone better than the team that we have today. The first talk will be on wide QRS tachycardias. Usually we structure it in a way that this one topic is on the ECGs. So wide QRS tachycardias, an ever-perplexing topic. I hope Dr. Suresh, Professor, Department of Cardiology, CMC Vellore, will make things very simple for the cardiology students so that they can have all their clarifications also at the end of this session. This will be moderated by Dr. John Roshan, again, Professor and Head of the Department of Cardiac Electrophysiology, CMC Vellore, and Dr. Suresh. Following this, we move on to another topic in electrophysiology, measurement of HV intervals. Again, a very accomplished speaker, Dr. Karthikeya Bhargava from New Delhi. He will be taking the students through this particular topic, measurement of HV intervals in various types of brady and tachycardias. Again, this session will be moderated by Dr. John Roshan and Dr. Suresh. So over to you, Dr. John Roshan and Suresh, to introduce Dr. Suresh, and then you can take over the session, which will be lasting for another 1 hour. Each topic will last for 20 minutes, and that will be followed by discussion of 5-10 minutes.
Thank you, Dr. Deep, for the warm introduction. And we will now move straight off without any wastage of time. What do you say, Dr. Suresh?
Yes, we'll go ahead with the topic. Later we can discuss.
So Dr. Suresh is my colleague and professor in CMC Vellore, and he's going to be speaking to you about wide complex tachycardias. Over to you, Suresh.
Good morning, everyone. So can
you can go to
slides?
Yeah, just go to slideshow. Yeah, you're perfect. You can start.
Yeah. Sorry, there's an issue with my video. I'll just pause my video and then I'll start. Okay. Good morning, everyone. Today's topic, which I'll be dealing with, is a wide complex tachycardia. It's basically a discussion on ECG and differentiation among various wide complex tachycardia. As Dr. Deep was saying, it's an ever-perplexing topic, which has important therapeutic connotations. I'm not able to move my slides. Yeah, sorry. So what I'll be doing today is basically discuss about the regular broad complex or wide complex tachycardia. I'll be dealing only with those regular tachycardias. I'll discuss in detail about the basic principles of ECG differentiation of these wide complex tachycardias, and briefly about how these basic principles are bunched together into an algorithm or algorithmic approach. What are the limitations of ECG in diagnosis, and briefly again about clinical clues. So we all know that the evolution has given us a conduction system which conducts about 10 times faster than the myocardium. And also by the fact that the conduction system is right in the middle, the depolarization of the ventricles happens within 100 milliseconds or at the most 120 milliseconds. So all of us know the definition that a narrow QRS is less than 120 milliseconds and wide QRS is more than 120 milliseconds. So a tachycardia, which is more than 120 milliseconds and of course fulfills the criteria of tachycardia, is a wide complex tachycardia. Now, anything that doesn't follow this normal activation through the His-Purkinje system is bound to produce a wide complex. So about 80% of these wide complex tachycardias are actually VTs, where the tachycardia originates either focally or because of re-entrant entirely in the ventricle. So the conduction happens through myocardium, cardiomyocyte to cardiomyocyte, so it's much slower, and also it can arise anywhere in the ventricle. So that's the reason why it produces a wide complex tachycardia. The second group of tachycardias which can produce a white complex is produce a narrow complex tachycardia. It could be an atrial flutter, it could be AVNRT, an atrial tachycardia, an orthodromic reentrant tachycardia, that is a pathway-mediated AVRT, where it conducts down the normal conduction system and goes up to the pathway and forms a circuit. Under normal circumstances, these tachycardias produce narrow complex. There are two situations in which this can produce a broad complex tachycardia. One is when the tachycardia starts suddenly, it can produce what you call as a phase 3 block or a rate dependent block in one of the bundle branches. So it produces a bundle branch aberrancy, commonly left bundle, but it can also cause right bundle aberrancy. So that is one situation where you call a rate-related aberrancy can develop during these SVTs. So that's why they present as a white complex tachycardia. The other situation is when the patient already has an underlying bundle branch block. Obviously, anything that conducts down that disease conduction system will produce a broad complex tachycardia. The third group of disorders, the tachycardias, which produce broad complex, is when there is an accessory pathway that is able to conduct antegradally, that is from the atrium to the ventricle. Because it's not following the usual His-Purkinje system, it is bound to produce a white complex. Now, there are again many different SVTs which can conduct down the pathways. So those are called where the pathway is not part of the circuit, but it is a bystander pathway, but still it produces a broad complex because the activation is partly through the AV node and partly through the accessory pathway. There is one tachycardia where the pathway is accessory pathway is part of the circuit and accessory pathway conducts antegradally from the atrium to the ventricle, and it can go back to the normal His-Purkinje system. This is what we call as a true antidromic tachycardia. Now we can group all these tachycardias, including the true antidromic tachycardia and where the other SVTs with the bystander pathway, into so-called pre-excited tachycardias. In general, the pre-excited tachycardias form a very small minority of these tachycardias, depending on what you practice. In an emergency physician or a general cardiology practice, it's the pre-excited tachycardias are less than 1%. They increase to about 1 to 5% if the series is from an EP center. So, broad complex tachycardia, the most common cause is VT. Almost 4 to 1 times it is going to be VT. The remaining 1% is going to be SVT with aberrancy, and pre-excited tachycardias are the most uncommon. So my discussion, in general, again, the differentiation is mainly between the VT and SVT with aberrancy. Where relevant, I'll just speak about pre-excited tachycardias. Now, basic principles of ECG, the differentiation between these different VT versus SVT with aberrancy, we follow certain basic principles that have been sort of introduced one by one since 1960s to 70s and have stood the test of time. And so I'll go one by one in the order probably of importance. So the first one is, what's the relationship between the atrium and the ventricular activation? Now, on ECG, we call that a P and QRS relationship. So if you see the right side, we have a ladder diagram where the top part is the atrium, then we have the AV junction. I've just labeled it AV junction, which includes the AV node and the His, and then we have the ventricle. Now, the first two beats are sinus beats. It's starting in the atrium, there's a small delay in AV junction, and then the ventricle is being activated. Just a second. Yeah, I hope you see my pointer. Can you see my pointer? Yeah.
Yeah, we can see it, Suresh. We can see it. Please go ahead.
So then what we see in red is actually a ventricular tachycardia starting here. Yeah, I know this ladder diagram is not, most of you probably are not familiar, but it's a good idea if you really want to understand the nature of arrhythmias or the mechanism of arrhythmias. It's good to yourself draw these diagrams and try to understand the arrhythmia concepts that will make you understand better. So you can see that the ventricular tachycardia started. Now, there are a few things that can happen when a ventricular tachycardia. So the rhythm is originating from the ventricle. In about half of the ventricular tachycardias, this ventricular rhythm can conduct through the AV junction back into the atrium. So there can be a AV relationship of 1 to 1. or it can be some sort of 2:1 or a Venke backing phenomenon, but more commonly it can be 1:1. In a different scenario, if the AV junction is not conducting retrogradely, what happens is the VT is happening, but the VT gets blocked retrogradely in the AV junction. So the atrium is going on its own rate and the ventricle is going on its own rate, and the ventricular rate is higher than the atrial rate. So this is what we call the classic VA or AV dissociation. So V's are more than A's, and A is independently going, atrium is independently going on its own, independent of the ventricular activation. So when you have this V2A, this happens in the rest of the 50% of the tachycardias. So when you have this AV dissociation or the VA dissociation, if the antegrade conduction, which is intact in most cases, what happens is it can, an appropriately timed atrial beat can sometimes go through the AV junction antegradely and sort of collide with the activation in the ventricle in the ventricle. So this is what we call as a fusion beat. The ventricular activation is a fusion between the atrial rhythm, which is sinus rhythm, and partly the ventricular rhythm. Now, if you have another appropriately timed the sinus beat, what it can do is it can completely capture the ventricle. So for one beat, the whole of the ventricle is being captured by the sinus beat, and the VT continues. So these are called fusion beats, and then the second one, what we discussed, is the capture beats. These are all different manifestations of AV dissociation. So AV dissociation is when you have V and A going on at independent rates with V more than A, and you have capture beats and fusion beats. If you take the SVT with aberrancy case, usually it is 1:1, but if it's like something like a flutter or various situations where there can be a block in the AV junction, then it can be something like 2:1, or even it can be a Venke backing in the AV junction. So we call that SVT with a block. Now, in these situations, the ventricle is never independent of the atrium. It has to be either 1:1, or it is some multiple or some relationship between the atrium and ventricle. It can never be a VA or AV dissociation. So it can be 2:1. The atria can be more than ventricle, but it is always, there is some sort of relationship between the atria, because the atrium or the supraventricular tachycardia is the driver of the ventricle. So it has to be associated with the ventricle. So you can never see a AV dissociation with an arrhythmia happening in the atrium. So if you see this ECG, how do you identify that? Yes, of course, you have to look for the P waves. If you carefully look for the P waves, this is a very good example of P waves which are clearly seen. It's not always like this, but if you can see something like this where the P waves are marching through the this wide complex tachycardia, you know that the A and B are dissociated. For all practical purposes, this is a ventricular tachycardia. Now, if you carefully see the rhythm strip here, you can see that these two beats are narrow QRS beats preceding by a P wave. So these are the capture beats where the ventricle is captured entirely from the atrial, the sinus rhythm above. Now, if you see again carefully, there are beats which are not as narrow as the capture beats, not as broad as the VT beat here. So you can surmise that this is actually a fusion between the ventricular tachycardia beat and a sinus beat. So this ECG is good in the sense that it has all three manifestations of AV dissociation, where you can directly see the AV dissociation where V and A are dissociated. You have capture beats and you have fusion beats. So these are diagnostic of AV dissociation, and these are diagnostic of VT. A wide complex tachycardia with AV dissociation has to be VT. The only other situation which probably occurs with some frequency where you have a wide complex tachycardia with V's more than A and VA dissociation, but it's not a VT, is in the post-op setting, especially after cardiac surgery in children, you see a junctional ectopic tachycardia. And the surgery itself can sometimes result, like if you were doing a TOF surgery, that's probably the most common situation, itself can result in a right bundle branch block. So you have a right bundle branch block, broad complex tachycardia arising from the junction. And this junctional tachycardia can retrogradely block into the atrium. So in that specific situation, that is one rare example of where you have a wide complex tachycardia, VA dissociation which is not a VT, which is a junctional ectopic tachycardia with a VA block. There are much rarer examples called nodovascular and nodoventricular, which probably I don't want to bog you down with those details. But probably these are the two situations. And if the appropriate setting is not there, not a post-op, not a kite, not a jet, then for all practical purposes, if you have a VA dissociation, that has to be a VT in the setting of a broad complex tachycardia. So that's a very specific, it's almost diagnostic of a VT. The problem with this is it has low sensitivity. As we discussed, 50% of the ventricular tachycardias do not have a VA dissociation. They have V2A1 conduction. Even among those patients, the remaining half where there is VA dissociation, it's very difficult to identify the P waves. And if the tachycardia rate is not slow enough, there won't be any capture beats or fusion beats. It's difficult to capture the ventricle or fuse the ventricle. So the sensitivity is only about 20%. That's about 20% of VTs only you can see these signs of AV dissociation. Not that it is not there in the remaining, it's seen about 50%, but it's difficult to identify. That's the thing. So again, the capture and fusion beat requires slower VTs. So it's typically seen in VTs which are slightly slow. So it's a very specific finding, but low sensitivity. So the next relatively specific finding which we'll come to is the QRS concordance. To understand this, it's good to just get an idea of how the precordial leads sit in relation to the heart. So this is a heart specimen, and you can see these are the leads, the precordial leads V1 to V6. Roughly, the V1 is onto the right of the patient and right of the midline, and V2 is slightly on the left of the midline, and then we have all the V2, V6, V3 to V6 going laterally and away more apically. So this is the same thing which you are more used to. This is sort of plaques view on the left. You have the left ventricle and the right ventricle. You can see anterior posteriorly how the leads sort of sit. And this is sort of a fourth chamber view where you have from right to left how the leads sit. Now, when you have an SVT with aberrancy, let's say right bundle, here the right bundle is blocked. So your activation is entirely going to the left bundle. Now the left bundle or the right bundle arborizes somewhere in the mid part of the rhythm. That is not entirely basal, not at the AV annulus, not at the apex, somewhere in between. So when an activation, ventricular activation somewhere starts somewhere in between, not right at the base, not at the apex, you see some form of transition between V1 to V6. You don't see complete concordance between V1 and V6. The same holds true for the left bundle branch block. If you have a left bundle branch block, the activation happens on the right side of septum, not at the apex, not at the base, somewhere in middle. So you expect some transition. So in any SVT with aberrancy, you see this transition. Of course, VTs which arise in that region or mid part, not basal, can also produce this transition. So again, this is not a sensitive finding. But if you see something like this, where let's say the ventricular tachycardia is arising from the extreme base that is close to the AV annulus, in this case mitral annulus, especially in the posterior basal region, the whole of the ventricular activation is happening towards these leads, right from V1 to V6. So if you see on the right, again, it's the whole of the ventricular activation is coming from V1 to V6. So what this does is it causes a monophasic R wave or a predominant R wave in all the leads from V1 to V6. That is what we call as a positive concordance. In this case, if you see that the right bundle is there and you can see that right from V1 to V6, it is positive. So this has to arise quite basally, which is not possible for a SVT with an aberrancy to have. Okay, so a positive concordance is again a relatively specific finding for VT, but again, not all VTs have this concordance. So absence of positive or negative concordance doesn't mean anything, but if it is seen, it is a relatively specific finding for a VT. The same thing, if you have a VT or a ventricular activation that is arising from apex, especially anteroapical region. So the whole of the activation is going away from these precordiales, V1 to V6. Depending on whether you have right side or left side, you will see a complete negative concordance, or you can see right bundle in V1 and then negative concordance in the rest of the leads. So that is what we call as a negative concordance. So if you see this ECG, you have a left bundle type of morphology and you have negative QRS complexes right from V1 to V6. So this is negative concordance again. It's a very specific finding for the VT. Just going back and seeing. So when you have a basal VT, something like this, this is a VT that's arising from the basal region, you said with positive concordance is seen in V1 to V6. One exception to this rule that is that the AV bundles, that is accessory pathways or bundle of, can also insert in this just around this annulus. So at the basal level, depending on whether it's posterior or anterior, it's always at the basal level. So a pre-excited tachycardia also activates the ventricle from this side, which is very possible. So it can really produce a positive concordance. So if you have a positive concordance, it's almost always VT, but it could be a pre-excited tachycardia because of this exception which I discussed. But if you see a negative concordance, there is no accessory pathway that inserts at this point in the apex. So if you have negative concordance, it's relatively, it's much more specific. So if you have negative concordance in the precordial leads, it's almost diagnostic of VT. If you have positive concordance, it's very specific, only the exception being a pre-excited tachycardia. Again, because VTs do not necessarily arise around the macral annulus or the apex, other VTs can show transition. It's not a sensitive. They're very specific but low sensitivity. The next one I would go to is QRS axis. So again, if you have a right bundle during the QRS axis, the left bundle is conducting normally. So most situations, the left bundle, because it's conducting normally, the axis is usually preserved unless there is some structural heart disease, or it can, because the right side of the heart is getting, the right ventricle is getting activated later. So the terminal or the predominant QRS vector is deflected towards the right. So generally when you have a right bundle, usually it is normal axis, but you can see a right axis deviation. This is when you have a rate related aberrancy or a fixed aberrancy due to right bundle. Now, if you see the left bundle again, it's either a normal axis or because the terminal, the whole ventricle, the left ventricle is activated very late, you will have the QRS vector directed towards left side. So left bundle, again, the norm is you have either normal axis or a left axis deviation. So when you see an axis that is completely northwest, that is into the left upper quadrant, then any combination of these bundle branches will not produce this axis. So if you have an axis that is northwest, that cannot be explained by your bundle branch aberrancy. So this is a very specific finding for a VT. So if you have a QRS axis that is northwest, that is very specific for a VT. Now, if you see this ECG, of course, there is negative concordance in this, but if you leave that aside, you see the axis in the precordial lead, the frontal plane leads, you can see that its AVR is completely positive, 2, 3F is negative, 1 is negative. So this is in the northwest axis. This is highly diagnostic of a ventricular tachycardia. Now, the same caveat, if you have a right bundle, so the norm is you should have a normal axis or a right axis deviation. But if you have the opposite axis, that is a right bundle with left axis deviation, in this case, where you can see that the right bundle tachycardia with, you can see one is positive, AVR is positive, AVL is positive, it's a left axis deviation. This is again highly suggestive of a ventricular tachycardia. Or a left bundle with right axis. If you have a left bundle with a right axis, that's the opposite axis. This is again highly suggestive of a ventricular tachycardia. So just briefly, if you have northwest axis or a right bundle with left axis or a left bundle with right axis, these are specific for VT. But again, these are not sensitive finding, but not all VTs have this features. Now, one exception for all these criteria, which based on morphology or duration, is that if patient has a pre-existing extreme deviation in the axis, that is the sinus rhythm itself has an extreme northwest axis, of course, none of these criteria hold true. So that's the importance of comparing after the reversion of the tachycardia with the sinus rhythm ECG. Now, again, briefly about the QRS duration. Generally, a typical left bundle or right bundle, which happens with the aberrancy, are narrowish in the sense that when you have a right bundle tachycardia, usually aberrancy is less than 140 milliseconds, left bundle aberrancy is less than 160 milliseconds. So when you see durations longer than this, that is right bundle aberrancy with more than 140 or left bundle with 160, this suggests that the connection is not because of aberrancy, but probably going from cell to cell, and that's why it suggests a VT. There are again many exceptions to this criteria. One is many patients have probably or antiarrhythmics if there are for 1C drugs for typically in the flecainide. We quite often see that in patients with atrial fibrillation. So when they have an AF episode on flecainide, they can have, especially if they're taking a high dose, they can have a very broad QRS, which looks like a VT, but actually it's a SVT with aberrancy. or patient has a pre-existing broad IVCD. The other exception is again a pre-excited tachycardia. So the duration criteria are not so specific, not so sensitive because of these wide exceptions. So we need to be careful about this thing. The other way, it can also happen the other way. There are some ventricular tachycardias, if it happens close to the septum, that's the interventricular septum, or close to the conduction system, it can produce a relatively narrow QRS. So it's less than 140 milliseconds or 160 milliseconds in this thing. So a VT can present with a, so we call it as a narrowish VTs. So that's why this duration criteria are not very strong. So we need to take it with a pinch of salt, and we need to use it along with other criteria. So one simple tenet is that QRS duration that is shorter than that of the sinus rhythm is almost always a ventricular tachycardia. That means your tachycardia QRS, if you have a comparison sinus rhythm ECG, if it is narrower, it has to be ventricular tachycardia, because at a faster rate, if at all, the fixed aberrancy should worsen. So it should become broader. It cannot become narrower. The fact that it is become narrower means that it is not getting activated through the way it is being activated during the sinus rhythm. So a QRS during tachycardia narrower than the sinus QRS is diagnostic. This is rarely seen, but you see that that's an important clue. Now, coming to the QRS morphology. So when we say right bundle, left bundle, there are two things which we need to keep in mind. Is it a typical left bundle? So for example, this tachycardia is a left bundle tachycardia. All of us would say this is a left bundle. But if you see carefully that it fulfills the criteria for, or at least the most of the criteria for a typical left bundle branch block. You have a RS, a sharp initial deflections, you have a normal transition, normal axis. So this is a typical left bundle. This is what you would expect a left bundle to be in, even in a sinus setup. Or this is a left bundle tachycardia. Again, we call this left bundle, but you see that this is not a typical, the look of it, the global picture of it is not a typical left bundle. So it's important to differentiate whether it's a typical bundle branch block or it's a bundle branch block. Like we use the term left bundle tachycardia, but is it typical or is it like a bundle branch block? Similarly, this, if you see this tachycardia, it is typical right bundle branch block. You have all the features of right bundle. But if you see this, even though we call it a right bundle branch tachycardia, this is not a typical right bundle branch tachycardia. So the rule number one is, if it is rate-related aberrancy, it should produce a typical bundle branch block. So if the sinus rhythm is narrow and you don't see a typical right bundle branch during tachycardia, then the WPC is not typical right bundle. It has to be VT. It's likely to be VT. Of course, if the sinus rhythm already shows an atypical bundle branch block, that's possible. But if sinus rhythm is narrow, then that has to be a VT. So the second important concept when you're using morphological criteria is, when you have a bundle branch block, your initial activation, let's say this patient, in this case, is a right bundle branch block. The left bundle is normal and conducting normally fast. So the initial activation of the ventricle is happening relatively fast because it's happening through the normal conduction system. But as it then goes cell to cell and depolarizes the right ventricle, in this case, right bundle, so the terminal part is much slower. If you take the initial 40 milliseconds or whatever duration and the terminal duration, you can see that this has much greater amplitude compared to the terminal 40 milliseconds of amplitude. So what we call this is the initial voltage and the terminal voltage. So when you have an initial voltage, that is the initial depolarization are sharp, high voltage compared to the terminal voltages, which are sort of slow slew rate or and broad, then that suggests a SVT with an aberrancy. This is an aberrancy. In the setting of VT, the initial depolarization itself happens to the cell to cell. So you have a slow slurred QRS initially. Once it starts engaging the conduction system and depolarizes the septum and reaches the other side, then you have a rapid depolarization. Relatively rapid, not very rapid, but relatively rapid depolarization. So the initial depolarization, the VI, is less than the terminal voltage. So when you have the initial slurring, terminal rapid, that suggests a VT. So these are the basic principles, whether it's a typical left bundle or right or atypical or sort of left bundle like, and how is the initial and how is the terminal voltage. These form the basis for most of the morphological criteria. Now, if you see this, if you have a right bundle like morphology, if you have a typical, the look itself, if you see V1 and V6 and you say, okay, this looks like a typical right bundle with a triphasic, then it is likely to be SVT with aberrancy. But if you see something odd, like a monophasic R or a QR or R prime, and a deep S wave in V6, which are not seen with the typical right bundle branch block, then all of these features suggest ventricular tachycardia. Same thing holds true for ventricular tachycardia with left bundle morphology tachycardia. That is, if you have a monophasic R that looks like a typical left bundle in V6 and 1 AVL, then that suggests of SVT. But you have these broad, bizarre complexes, then that suggests it's a VT. Now again, because the initial deflections in VT are slower, you have longer initial deflection. So initial R more than 30 milliseconds, R2S more than 60 milliseconds. All these are again features of the same manifestation of the same phenomena that we saw, that the initial conduction happens myocyte to myocyte. So that's suggestive of VT. Now, the important caveat is based on morphological criteria alone, there are some VTs which some of them, like the first VT, which is a fascicular VT, is a relatively common VT, which can be misdiagnosed as a SVT. The other thing is much rarer, probably a cardiologist probably may not see it, but that's the bundle branch related VT where the VT happens in this. These are two exceptions where the VT may look, based on the morphology alone, look like typical left bundle and does not fit into the features of typical left bundle or right bundle, does not fit into the morphological criteria of VT. So we may have to use other criteria. So for example, this is a case of vascular VT. You have in fact a small R, so you have a triphasic RSR with all the features suggesting it's morphological features suggesting it's SVT, but it's actually a VT based on other criteria. Now this is another, which looks like probably some atypicality, but more or less a left bundle, but this is actually a bundle branch sensitivity. But these are rare exceptions. Generally, morphological criteria are relatively sensitive and specific. Now, another important aspect is comparison with sinus rhythm QRS. So that's probably most important, because every criteria which we have seen, there's an exception that if the sinus rhythm already shows this, then you cannot use this criteria. So important thing is, if your axis, duration, morphological criteria, it's important to compare with your sinus rhythm ECG. If they already have a fixed axis or a wide QRS or something morphology, the same thing suggests it's a SVT and not VT, even though it suggests the features suggest VT. If the axis especially deviates more than 40 milliseconds, 40 degrees from the sinus QRS, it's highly suggestive of a ventricular tachycardia. Now, baseline ECG is normal and you have an atypical bundle branch. That's what we have shown, not a typical bundle branch. It's highly suggestive of a ventricular tachycardia. Now, just to go about a typical ECG, each of you will develop your own way of going through the ECG, but this is how I look at the ECG when I'm analyzing the wide complex tachycardia. So using the same criteria, so what I look at is first the rhythm strip. If rhythm strip already shows obvious AV dissociation, I don't think you should even go into the other. Most, for all practical purposes, it's a VT. Second, you look at the morphology, whether it's a right bundle or left bundle, whether it's a typical right bundle or a left bundle. Then I look at the transition, how it happens, is there any positive concordance or negative concordance? These are relatively specific findings. So if you find this almost, you'll make diagnosis in most of the cases. Now, if you are not able to diagnose based on these, then you'll have to look into the axis and the individual morphological criteria, which takes slightly longer and they're not relatively that specific. So the sensitivity and specificity of these criteria, again, I don't have numbers because they have not been formally tested, but based on general experience and expert consensus, the AV dissociation and precordial concordance is very specific, but as we discussed, it has a low sensitivity. An abnormal axis, that is the northwest axis or LBBB and right bundle, have moderate sensitivity, and the specificity is also in the moderate range. Now, this terminal and initial, which I discussed, the initial less than the terminal, is a good sensitivity and specificity for the VT. And most of the morphological criteria also depend on this. So that is true. And whether it's typical or left bundle also is a good sensitivity and specificity. Probably the one thing which you should always be careful about using QRS duration of criteria. This is one criteria which almost many times goes wrong. So you use in conjunction with other things, but don't use it as a standalone criteria. Now, because none of these criteria is diagnostic, obviously. To diagnose VT with much more better sensitivity and specificity, what has been traditionally done is bunch them up into a sort of algorithm. You go step by step or you assign points to it. The first probably multi-step algorithm is Brugada. Previously, all these criteria were described till 1998, but you have the first multi-step algorithm by Brugada. There are multiple more. Slightly more, this is the most popular or most widely used. Then there are probably Vericase, what I would suggest is the second most commonly used. There are multiple other, using the same criteria, arranging them or using different ways of utilizing them, you arrive at a diagnosis. So for example, this multi-step algorithm here, you see that this is a Brugada algorithm where you see no precordial lead has a both R and S. This essentially says that it's if there is precordial concordance or a negative or positive concordance. If you have negative concordance, there won't be S. R, if you have positive concordance, there won't be S. So it's another way of saying you have concordance. Then these are the morphological criteria. Use the morphological criteria. You have AV dissociation in this criteria, and again this morphological. This is a duration criteria, and this is a morphological criteria. So you go step by step. If yes, 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 or no, 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 then you just diagnose VT. If none of them are true, you diagnose SVT. Similarly, this is what you call the Vericase algorithm. You use this initial deflection versus the terminal deflection and initial R wave arranged in a sequence. So for example, in this case, the initial deflection versus the terminal deflection is much slower. So it's a SVT with, faster. So it's a VT. So the problem with this multi-step algorithms is at each step, if you're sure that this criteria holds true, then you go down it smoothly. But if, say, for example, in step 2, where the R/S is more than 100 milliseconds, if you're sure that it is unsure whether it is 80 or 90 milliseconds versus 110 milliseconds, which quite often happens with ECG, with manually read ECGs, then you can easily go the wrong path when you utilize these algorithms. The other thing is, once you stop there, you are not encouraged to use this AV dissociation, other criteria, which actually may be pointing towards a different diagnosis. So when you use this multi-step algorithm, if you're not sure of adjudicating it to this particular step, then you may go down the wrong way and make a wrong diagnosis. But if you are able to definitely say that each of these criteria then they have good sensitivity and specificity and accuracy. So you can use Brugada or any multi-step algorithm, but also make sure that you go down the whole thing and also you give some margin of error. How sure am I with this particular criteria? Am I absolutely sure that yes, this S2 more than S is more than 100, or is it like borderline? Then in that case, we may have to use other criteria as well. So to overcome those problems, there are other ways in which these criteria are arranged. One is each criteria certain point based on certainty. So these are point-based scoring system or based on Bayesian approach. These are slightly more, probably a little bit more accurate than the other things, but the problem is they're more cumbersome to do in a clinical setting. So they're not frequently utilized. So the limitations of the ECG, general thing is if you have this multi-step algorithm or you combine the criteria very well, you know the criteria and you utilize them well, you can diagnose VT with a good certainty in almost 90% of the cases. So the sensitivity and specificity approaches 90%. But there are situations in which morphology alone can differentiate it, especially from a pre-exit tachycardia. Some of these VTs can be narrowish, so you may misjudge them as SVTs. And again, you have to remember that there are VTs which have not been well represented in any of these studies, like idiopathic VT, bundle branch-oriented VT, or pre-exited tachycardias. So these are underrepresented. So the exact the sensitivity and specificity in these conditions is not known. So these are the usual ones which are slightly misdiagnosed. So when you have that already 90% accuracy, to improve it, you can use clinical clues. So to start with, you already have a pretest probability of 80% when it's a the wide complex tachycardia of it being a VT. So you start with that and you add more clinical information. Say, for example, if the patient gives history of structural heart disease, old myocardial infarction, the probability almost increases to more than 95%. If the patient has old myocardial infarction and patient has a wide complex tachycardia, until proven otherwise, it's a ventricular tachycardia. Of course, those of you who are astute clinical examiners, you can use clinical tools like intermittent Canon waves or variable first taxon, which are markers of AV dissociation, and diagnose the tachycardia. So more recently,
we are running a little short of time, sir.
Yeah, I'm done. I'm wrapping it up. So this is algorithm where use clinical criteria as well as the ECG criteria and simplify, just utilize the initial and the 40 milliseconds, what is the time to peak, and just use the information on structural heart disease and simplified this. So this algorithm has performed equally well in comparison to other. It's much simpler to administer. And it doesn't matter who administers, whether it's EP attending to cardiology attending to internal medicine. This has, because it's a much simpler algorithm, it works well irrespective of who administers it. So these are three great articles, which I suggest everyone who's going for an exam or otherwise who's interested to read these articles. These are all review articles, give a good overview of all these criteria and acclimatize you to differentiation of this. Thank you.
Very nice and exhaustive talk, Dr. Suresh. So just in the chat box, some questions were there, and then one or two points I would like to emphasize. Like most of the postgraduates, they think if there's hemodynamic compromise, then it is a VT. But if there's no hemodynamic compromise, it is a SVT. But we should not go by the hemodynamic status, because most of the slow VTs, which someone was asking in the chat box, they can have the hemodynamically very easily well tolerated. But if on the contrary, if the SVT is more than 200 rates per minute, IHRS tachycardia, SVT with aberration, they can have hemodynamic compromise. So that is one thing. And second thing is you have to see the P wave. We elicit the P wave for the AV dissociation. So lead V1 is the best one to see. You can use the Lewis lead for better appreciation of the P waves. So that's the thing I would like to tell from my end. I think otherwise all the other topic has been well covered.
Thank you, Suresh, for the lovely talk, and Suresh for the very valuable points that you made out. I think since we are running short of time, let's move on to our next talk for the day. So I now welcome Dr. Karthikeya Bhargava, who is an exceptional electrophysiologist in the country. He's very well known, and he's also published books and multiple papers. So Karthikeya, it's a pleasure to have you at this forum, and please go ahead with your talk.
Thank you, John. Can I request to please stop sharing so that I can share my slides? Thank you. So, yeah. So my talk is to interpret HV interval in various arrhythmias. So what I am going to do is, since it is the talk for DM and DNB students and maybe some electrophysiology fellows, I'll try to make the concepts of HV interval clear first, and then we talk about different brady and tachyarrhythmias. Now, if we are short of time, please interrupt me. I'll stop there, but I'll try to complete these concepts first so that the understanding becomes easy. And whenever you are dealing with any arrhythmia or an EP trace, you will be able to interpret it correctly. So we know the normal cardiac conduction system. The impulse arises in the SA node, goes to the right and then the left atrium, and also to the AV node, and from there to the His bundle, and then the bundle branch divides into the left. The His bundle divides into the left and the right bundle, and then the left bundle also divides into multiple fascicles. And through these bundle branches and fascicles, through a network of Purkinje fibers, ventricles get depolarized. And this cardiac activation sequence results in the recording of an ECG on the surface. And we know that the PR interval that we record on the surface is from the onset of atrial activation, typically in the SA node, and then to the onset of ventricular activation, that is in the ventricle. So it actually covers the entire cardiac conduction system activation, which is happening over the cardiac conduction system. But there is a very important step which we miss on the surface ECG, which we are not able to record, and that is the His bundle. And when we do an electrophysiology study, we place a catheter in the septal leaflet of across the septal leaflet of the tricuspid valve to record this His signal. And this can divide the PR interval into three different intervals. That is the PA interval, which is from the upper right atrium to the lower right atrium, the AH interval, and the HV interval. Now, so this is how we place the catheters. See a catheter being placed in the His bundle region. Sorry, I'll just add a pointer. So this is a quadripolar catheter placed across this tricuspid leaflet and which will record the His bundle deflections. Now, this actually divides the PR into the suprahisian part, that is in which is in under the influence of the autonomic tone, and the infrahisian part, which is not affected by the autonomic influences. Now, and this is very important concept that uh, to understand different arrhythmias, and there have been many attempts to record the His bundle on the surface ECG itself, but they have never been too successful to be applied in clinical practice. So when we do an EP study, the most important catheter that we place is the His bundle, which is important to understand the mechanism of the arrhythmia or conduction defect that we are encountering in a particular patient. Now, how do we measure the HV interval? Now, the HV is placed, His bundle signal is recorded from the septal leaflet across the septal leaflet of the tricuspid valve, and we record the His bundle interval from the onset of the His bundle electrogram in the His signal itself, and then from the ventricular activation wherever it is occurring earliest. It may be the surface ECG, it may be a intracardiac electrogram, wherever the ventricular activation occurs first. That is the point to be taken for recording the HV interval. And normal conditions, the normal HV interval is between 35 to 55 milliseconds, and it can get prolonged in certain disease state and could be shortened because of certain other reasons. Now, but important to realize is that it is always the earliest ventricular activation, that point that you have to take, since ventricle is a large structure. It includes the right ventricle, left ventricle, and multiple segments of each. And so wherever the activation is occurring first is the point to be taken to measure the HV interval. Now, what happens if there is right bundle branch block? Now, if the other bundle branch, that is the left bundle branch, is conducting normally, the HV interval in right bundle branch block will indicate the conduction time interval in the His and the left bundle branch. And if the left bundle branch conduction is normal, the HV should be in the normal range. If the HV is abnormal, that means the left bundle branch conduction is also delayed, and hence your conduction time from the His to the ventricle is delayed. Now, now we understand that HV is usually normal if the QRS is narrow and normal. But can the HV interval be prolonged with a narrow QRS complex? Sometimes we see EP reports which are fallacious, and we see that although the ECG is entirely normal, the HV has been reported as longer. But still, we should understand that HV can be prolonged in a narrow QRS, though it is very less likely, but it can happen in a couple of situations when the disease lies within the His bundle itself, and this will result in a His bundle recording which will show a fragmented or a split His signal, and the disease actually is intrahisian. Rarely, and it is theoretically possible, but practically may be difficult to have it in clinical practice, when both the right and the left bundle branch have equal amount of delay, then the HV may be prolonged, but the QRS may be entirely normal. But this is more theoretical than practical. Now let's look at another tracing. Now this is EP tracing that we record whenever we place catheters in a person who has at baseline during sinus rhythm. And typically the way we see these electrograms is the surface ECG lead from top to bottom, lead 1, lead 2, and lead V1. Then the high right atrial recording by placement of a catheter in the high region of the right atrium. Then the His bundle electrogram recording from proximal and distal electrodes. Then the coronary sinus electrogram, which is an again left annular structure. So record the signals from both the left atrium and the left ventricle. And from proximal to distal, they are displayed here from CS 910 to CS 12. And finally, the right ventricular apical electrogram. Now, if you just look at the His bundle electrogram, you may feel that the HV is actually normal. But remember that whenever you have to measure the HV interval, the onset of the His is your first point, and onset of the ventricular activation wherever it is occurring should be taken as the second point. And here you see that the ventricular activation in the CS12 is much earlier than in His signal, and so the HV actually is 20 millisecond, which is much shorter, and that is because of ventricular pre-excitation due to presence of an accessory pathway. This actually can be very well easily recognized on the surface ECG. Remember when we look at EP tracings, we record at a speed of about 100 millimeter per second, in contrast to surface ECG recording, which are as a standard we record at 25 millimeter per second, because we are more concerned about measuring the intervals more accurately. Now, this was actually very well known that if you have short HV interval, this is a paper from 1971. If your HV interval is short, there are mainly two possibilities. One is that there is a ventricular pre-excitation due to an atrioventricular accessory pathway, which are also called as bundle of Kent, or there may be a ventricular excess systole or VT, which results in shortening of the HV interval. Now, we heard a wonderful talk about wide QRS tachycardia and how do we differentiate that on the surface ECG. And then, can HV interval help in differentiation of a wide QRS tachycardia? As we know now that wide QRS tachycardia can have three major differential diagnoses. One is when you have any SVT occurring with a bundle branch block. Second, when we have an SVT where the antegrade conduction from A to B is occurring over in the accessory pathway. And third, when we have a ventricular tachycardia. Now, when we have a bundle branch block, we just heard that the HV interval will be normal or maybe prolonged if the other bundle is also has a disease. And so in SVT with bundle branch block, whether it is pre-existing or occurs as an aberrant conduction during tachycardia, the HV interval will be usually normal, but maybe slightly prolonged. Whereas in a pre-excited SVT, whether the SVT, where the accessory pathway is actually a bystander and the tachycardia is occurring either in the atria like atrial tachycardia, flutter or fibrillation, or a AV and RT, the HV interval will be shorter because the one part of the ventricle is getting activated earlier than the other, and this results in pre-excitation, and pre-excite tachycardia will result in a shorter HV interval. Similarly, if you have a tachycardia where the accessory pathway is actually a part of the reentrant circuit and conducting from A to V, which we call it as true antidromic AVRT, the HV again will be short, and but here it is a true interval, as we will understand in the subsequent slides. Finally, in ventricular tachycardia, the ventricular tachycardia may actually conduct retrogradely over the His-Purkinje system or may block in the His-Purkinje system. And if it conducts, your HV will be shorter, but if it blocks, the HV actually is no interval at all. There is just one exception where the tachycardia is actually involving the bundle branches occurring in the left and the right bundle branches. And here his is activated retrogradely. And as we will see later, it's actually a HV interval is actually a pseudo interval and will be actually usually longer than that during sinus rhythm, but maybe shorter and in fact maybe zero as well. So HV can be very helpful in differentiation of a wide QRS tachycardia. Now let's understand what do you mean by true and pseudo interval. Now suppose you have your car is being driven on a road. There is a speed breaker at point B, and from point C, it has to go and hit a wall. Now, and you are measuring the C to D interval, that is from this point to the wall. And whenever it reaches, if there is only one pathway of conduction or travel, the car will travel from A to D, then C to D is a true interval. And if we extrapolate this, that C is your example of this situation will be during sinus rhythm when the impulse travels only from his to the ventricles. It can also be retrogradely, that is, if there is a VT can travel from point D to C to B to A, then CD will be actually negative, but it is again a true interval. There may be examples where you have an extra route of conduction from A to D, which actually is faster. There is no speed breaker in between, and this is akin to an accessory pathway. And in this situation, because this does not have a speed breaker, you may actually reach the wall D earlier from point A than taking the normal route from B, C to D. So in this situation, your C to D time will be actually shorter, and it is not a true interval because you are not directly traveling from C to D. Your conduction, if the travel time is less from A to D, your HV will be shorter. And if on the other hand, your time from C to D is faster than A to D, your HV will be same as a true interval. There may be another situation that you may have a problem where the car is actually driving from somewhere here and then it goes to the point D very quickly. But at the same time, it is also going towards C. The impulse is going towards C. And so now you can see that from C to D, if you measure, that is your HV interval, it is actually not a true interval or a pseudo interval. And this typically happens if you have a VT arising from one of the bundle branches, for example, from the left bundle branch, or another example is a bundle branch reentry VT, where the HV interval is a pseudo interval and there is no direct connection from C to D. And hence, this pseudo interval will depend on time taken from the reentrant circuit to the exit into the ventricle and the time taken from the reentrant circuit to travel to the His bundle. So pseudo interval and true interval concepts need to be understood to understand the HV interval better and what its role is in the mechanism of the arrhythmia. Another important point is the activation pattern in the His bundle. We saw that in the electrophysiological study, we placed a quadripolar catheter in the His bundle region. We can place a multipolar catheter. For example, this catheter has 10 poles, and then we can record the deflections, how the activation is occurring over His and right bundle branch. And so normally the His bundle activation will happen from proximal to distal. But if you have a pacing in the right ventricle or a VT occurring from the right ventricle, the activation will occur in the opposite direction from distal to proximal. And this point can also be very useful in understanding some of the arrhythmias, one of which could be a bundle branch reentry. Now, looking at particular arrhythmias, specific arrhythmias per se, let's look at bradyarrhythmias. Now, we often find a situation where a patient comes with a history of syncope in bifascicular block on the ECG. Now, we don't know whether we should implant a pacemaker or not because we don't know whether the third fascicle is conducting normally or not. So when we do an HV interval, this is one example where in this patient, the HV interval is absolutely normal in a patient who has right bundle branch block. And sometimes it may be normal at baseline, but you may provoke or stress the other bundle branch by either pacing the atria or giving some drugs like procainamide or ajmaline and find that the HV prolongs. That means the bundle branch is diseased and then probably patient needs a pacemaker. Another example where during the same right bundle branch block, the HV is markedly prolonged and this means the other bundle is also diseased and probably blocks conduction intermittently resulting in syncope. Now, another clue here, you find that there is another study in a patient with left bundle branch block. Again, you find that if you just look at the His bundle, you may think that the HV interval is actually markedly prolonged. But if you measure it correctly, you find that the earliest activation is actually occurring in the right ventricular intracardiac electrogram. And then if you measure, you find that the HV interval is actually normal and on the upper limit of normal. And so this patient probably does not need a pacemaker. So it has been studied that risk of progression of complete AV block in patients who have bundle branch block, a very old study from Dr. Scheinman way back in 1982 is actually one which most of us follow even today, that in patients who have HV interval which is normal in bundle branch block, the risk of progression over 3 years to complete heart block is 2%. But if the HV is 55 to 70, it goes on to 4%. But if it is 70 milliseconds or more, the risk is much higher. And that's why the guidelines say that if you have a prolonged HV of more than 70, you should implant a pacemaker. Remember, if the HV is very long, that is more than 100 milliseconds, then the risk is much, much higher of about 24%. Another recent study also looked at the morphology of bifascicular block and can it predict the risk of complete AV block, and found that patients who have right bundle and left posterior hemi block have a highest chance of progressing to complete heart block, which is more than that in patient with left bundle branch block and more than in patient with right bundle and left anterior hemi block. Now, sometimes when you are dealing with second degree AV block, like 221 block or Wenckebach block or Mobitz type 2 block, recording of the His signal not only helps you in taking a decision regarding the pacemaker, especially if the patient is asymptomatic, it will also tell you about the site of the block. So in this patient where you have 2 to 1 block with right bundle branch block in the conducted beats, if you look at the His signal, you find that the block beat have only atrial signal and no H and V, meaning that the block lies within the AV node. And so this is a 2 to 1 AV nodal block. And if the patient is asymptomatic, this becomes a class 2A indication. But if it had been a infrahisian block, even in asymptomatic patient, it becomes a class 1 indication for a pacemaker. Another example of this EP tracing where during atrial pacing, you find that there is 2 to 1 AV conduction, and you find that during the block beats, you have A, H, and no V, meaning that the block lies below the His bundle. And so you find you in this patient, the other bundle branch is also, that is the left bundle branch is also diseased, and stressing it by pacing the atria results in block in the left bundle itself, where the right bundle is already blocked in all the beats. Now, in intrahisian disease, you may find that sometimes your His signal may show a fragmentation or split signals. For example, in this, you have first degree AV block at baseline, but when you record the His signal, you find that the His has split signals, and these will are known as then H and H prime. And if you have to measure the HV interval correctly, you have to actually recognize the split His and measure it from the first recorded His signal. And this is one situation where even with a normal QRS complex, your HV may actually be prolonged. This is another example. A patient, elderly patient, comes to you with recurrent syncope, has a narrow QRS complex, absolutely narrow with left axis, and there is complete AV block on the ECG. And when you record the intracardiac signals, you find that the block lies within the His bundle, and you have A and H, which are related to each other, and H prime and V, which are related to each other. So you have situations where you have A and H, but no V, and you have situation in the escape rhythm where you have H prime and V. So the block lies between the H and H prime. And so this is intrahisian complete AV block. And it is one of the common scenarios which happens in patients, especially elderly patients and patients who have calcification in the mitral annulus and the aortic valve, because that is the reason where the calcium can impinge on the His bundle and can cause block within the His bundle itself. Now, looking at HV interval during tachyarrhythmias. Now, this is a typical trace that we see in a patient with a narrow QRS tachycardia with 1-to-1 relationship. Now, you see that there is a narrow QRS tachycardia going on. Again, remember, this is being recorded at 100 millimeter per second. And you find that there is 1-to-1 AV relationship. The high right atrium recording and the QRS, there is 1-to-1 relationship. And if you look at the His signal, the HV interval is actually normal and same as baseline. And if you look at the atrial activation sequence in the coronary sinus, it is proximal to distal. And if you have to look at the earliest atrial activation sequence, it is in the proximal coronary sinus CS910. So this is a narrow QRS tachycardia with 1-to-1 AV relationship with HV interval, which is normal and same as baseline. And so your differential diagnosis could be atrial tachycardia, AVNRT, or orthodromic AVRT. Looking at another patient who has WPW syndrome, and you have tracings during sinus rhythm, during atrial pacing, during the orthodromic reciprocating tachycardia, and after ablation of the accessory pathway, you have tracings during sinus and atrial pacing. And if you look at the HV interval during all these different timings, you find that during the sinus rhythm, the HV interval, the V is earliest in distal coronary sinus. And so the HV interval is positive, but shorter than 35 milliseconds, about 20 milliseconds. When you pace the atria, you find that your A to H interval prolongs and the conduction across the accessory pathway remains the same. So since the HV interval here is a relative timing between the conduction time from A to V over AV node His-Purkinje system and A to V over the accessory pathway, prolongation of atrial AH timing on atrial pacing results in fact, the HV becoming negative. The ventricular activation now actually is occurring earlier than the his, and so the HV becomes normal. During orthodromic reciprocating tachycardia, where the antegrade conduction is now occurring only over the AV node His-Purkinje system, your HV becomes normal. And once you ablate, the HV again becomes normal during sinus rhythm and even during atrial pacing, since now occurring activation over the ventricle is occurring over only AV node His-Purkinje system, your HV remains normal and same as during sinus rhythm. Now, this is another example where you have an atriofascicular accessory pathway. It is a unique accessory pathway which connects the right atrium with the right bundle branch, and it is slowly conducting. So during sinus rhythm, as in the first QRS complex in the left panel, you find that the HV is slightly shorter, but the QRS remains narrow. As you start pacing, you find that the His gets buried in the QRS complex. The QRS complex widens and the ventricular activation actually occurs earlier than the His bundle, because your pre-excitation becomes more and more, and your the timing from A to H becomes longer because of decremental conduction in the AV node. So your HV becomes negative during maximal pre-excitation, and this is the antidromic tachycardia, where the antegrade conduction is now occurring over the accessory pathway and retrograde over the AV node His-Purkinje system. And so you find that the HV is negative, and your His bundle activation now is from distal to proximal, which was earlier proximal to distal during sinus rhythm. So this is an example of an antidromic tachycardia or antidromic AVRT due to an atriofascicular accessory pathway, where HV will not only be negative, but the HV, the atrial, the His bundle activation will be from distal to proximal. So this is a cartoon showing the HV interval in various SVTs in patients who have pre-excitation. During orthodromic AVRT, since antegrade conduction is occurring over AV node His-Purkinje system, HV will be a true interval and will be normal. During antidromic AVRT, again the HV is a true interval, but the activation is occurring retrogradely over the AV node His-Purkinje system. So the HV interval will be negative, since the ventricular activation precedes the His activation. During pre-excited atrial tachycardia, where the accessory pathway just acts like a bystander, the HV interval will be short, and it is not a true interval because activation is occurring both over the AV node His-Purkinje system as well as over the bypass tract. Similar things happen during pre-excited AVNRT. So this is just a cartoon showing how the HV interval will vary in different types of pre-excitation. Looking at another example, HV interval in a wide complex tachycardia. Now, the first three beats are actually during atrial pacing, and you find that your HV interval is normal, but there is wide QRS complex due to right bundle branch block. Now, these first three atrial pacing beats result in initiation of a wide QRS tachycardia, which again shows a QRS which is positive in lead one. So this is a right bundle branch type of tachycardia. But when you look at the His signal here, it is buried within the QRS, and so the HV is actually negative. Now, so the first part was actually right bundle branch block aberrancy occurring due to atrial pacing. And the second part actually is tachycardia, which is also wide QRS but has a negative HV. So this has to be a ventricular tachycardia, since a normal HV during atrial pacing excludes the presence of an accessory pathway, and the only other possibility why the HV can be short has to be a ventricular tachycardia. Now, this is the same, the tracing depicted on the surface ECG. The first two beats are sinus beat showing right bundle branch block. Then you have atrial pacing, again showing the right bundle branch block, but with a normal HV interval. And this is followed by a fascicular VT with right bundle branch block and northwest axis, with which we just saw had a shorter HV or a negative HV. So this is how one can help use an HV to make a diagnosis if you have not realized that with just these 3 surface ECG leads, you may actually miss. And since the atrial activation is occurring nearly simultaneous because of robust conduction over the AV node His-Purkinje system in the retrograde direction, you may mistake this unless you have noticed the HV, which is short and negative, that it may be a typical AVNRT. Last slide. This is a rare arrhythmia, bundle branch reentry, so I'll not go into the detail. Here, the reentrant circuit lies between the right bundle and the left bundle branches itself, and hence when the ventricle is getting activated by exit from the bundle which is conducting antigradely, in this cartoon, the right bundle is conducting antigradely and then exits and results in depolarization of the ventricle. At the same time, it also travels retrogradely and activates the His bundle. And so your H to V interval is actually a pseudo interval. And typically in patients with bundle branch reentry VT, it is longer than the baseline and it is prolonged. But since it's a pseudo interval, depending on what time it takes for right bundle conduction antigradely and the time it takes to conduct retrogradely to the His bundle, that these relative time can change. And so your HV interval during the tachycardia can be actually shorter or in fact even be zero during tachycardia. So I think with this, I'll end, and apologies for having exceeded my time.
Very nice talk, sir. So there is a question in the chat box. What was the HV during PVC in last tracing?
The bundle branch reentry tachycardia?
That was a question, I suppose, from one of the...
Yeah, so in this example, the HV was longer than during baseline. It was about 65 milliseconds, where during baseline, it was about 55 milliseconds. This was a tracing taken from one of the books.
Thank you, Karthikeya. That was a lovely talk. You very comprehensively covered everything about the HV interval. Suresh, any further comments?
That's also, I think it's full. Everything has been very nicely explained, so there's no comments. I think we can go to the next part of the pacemakers talk.
Thank you. Thank you, Dr. Suresh and Dr. John Roshan, and the excellent speakers, Dr. Sirish and Dr. Karthikeya, for completing this session 1. It's been an excellent session 1. And then we move on to the device part of the session. Devices, as you know, all the DM and DNB cardiology trainees, when they come into the practice, you will be having opportunities to place the pacemaker devices and then complex devices. It is very important for you to understand how the pacemakers work. It is not only placing the devices, number 1. And number 2, how the most common problem that I hear from our students when they come out of practice and they come out of training and when they start doing is the incidence of infections is quite high. The device infections, we should all accept that is the Achilles heel of the pacemakers. Yes, we are moving towards the leadless technologies, but then for now, much of the device implants are wired pacemakers and put it in the pacemaker pocket. It's very important for us to understand how to prevent these CID infections. So hence we have 2 topics here. First, Dr. Rajiv Sharma, an excellent speaker, an electrophysiologist from Rajasthan. He's going to talk the students through the dual chamber pacing cycles. And the second talk will be on prevention of device infections by Dr. Abhilash. So this session will be moderated by, again, 2 great moderators, Dr. Chandramouli and Dr. Usnish Adhikari. So Dr. Chandramouli and Dr. Usnish, over to you. Please take over the session, introduce Dr. Rajiv, and we can get the session going.
Yeah. Thank you, Dr. Deep. I'm Dr. Chandramouli. So the topic is a very important topic, like it's regarding the timing cycles in a dual chamber pacemaker. Basically, these timing cycles are a set of rules that govern the behavior of the pacemaker, and these includes various periods or intervals or some modes and all. So though the terminology appears very familiar, but it includes a lot of mathematics, so it will be a bit confusing. Probably, so the students will be benefited by the great talk by none other than Dr. Rajiv Sharma. He is an associate professor in electrophysiology and heart failure from Mahatma Gandhi Medical College, Rajasthan. So over to you, Dr. Rajiv.
Thank you, sir. Is the screen visible to all?
Yeah, yeah.
Okay. So today's topic for dual chamber pacemaking parameters, timing parameters. I have kept the talk very basic and simple. So what are the timing parameters? These are low rate, AV and VA intervals, upper rate interval, refractory periods, and blank me periods. So what is the lower rate? It is the lowest rate pacemaker will pace the atrium in absence of intrinsic atrial event. As we can see here, the lower rate interval starts from here, and then if no intrinsic atrial sense event, it will pace the atrium after the lower rate interval. If there is atrial sense event in between, then it will start the new cycle and it will pace after that lower rate interval from that sensed event. So usually it is kept at 60 to 70, but in case of long QT, we have to pace atria at higher rates. In that case, we might have to pace at higher rates. Regarding AV delay is the pacemaker timing cycle. It is designed to simulate the natural pause between the atrial and ventricular events by mimicking the normal PR intervals seen in ECG. Benefit, we have to program it properly because it allows optimal timing for ventricular filling, which may contribute to improved cardiac output and allows sufficient time for proper mitral valve closure, and we minimize the diastolic MR. So AV interval is initiated by a paced or non-refractory sensed atrial event. If it is by after the pace event, then it is called as paced AV interval. If it is after sensed atrial event, then it is called as sensed atrial interval. So two things can happen after the AV delay. AV delay times out, and then the ventricular pacing spike is delivered, and ventricular pacing will be there. If AV delay is interrupted by a sensed ventricular event, then there will not be any ventricular spike, and there will be A sense and V sense, or A pace and V sense. As we can see here, it is A atrial pacing followed by pace AV interval, and after that ventricular pacing is there. And similarly, after the sense event, sense AV interval and ventricular pacing is there. If in between any ventricular impulse comes, then it will be sensed and there will not be any ventricular paced events. So what is the paced AV delay? It is the time period between the paced atrial event and the next paced ventricular event. Pacemaker spike initiate the paced AV delay timing cycle, and it can be programmed. Regarding sensed AV delay, the time period between the sensed atrial event and the next paced ventricular event, pacemaker has to sense the atrial event first, because pacemaker electrode has to sense the atrial signal and then start the AV delay. So there is a time lag. So that's why a sensed AV delay is usually programmed shorter than paced AV delay. Because we have to cover the delay of sensing from the pacing electrode of the atrial signal. So it is usually 30 milliseconds. So what is the clinical importance of this paced AV delay? This is ECG showing, because in pacemakers, we want less of right ventricular pacing. So what in suppose a patient is having sick sinus syndrome, or patient is having intermittent CHV in bivesicular block or trivesicular block, we want less of RV pacing. So if we keep AV delay shorter, as in the first ECG, there will be more ventricular pacing. But if we increase the AV delay, as we can see the second ECG, there is A pace and ventricular sense event. So we can minimize the ventricular pacing. That has two benefits, because it will decrease the myocardial demand first, and second, will be less risk. There will not be any risk of pacing induced cardiomyopathy. And we should always check AV conduction during the pacing implant. After the atrial lead is implanted, we have to check the AV conduction by pacing the atria at 120 or 130 rate. If it is very good, then we have to program AV delay longer, so that sensing, ventricular sensing is there. This is in contrast to CRT, where we need more pacing, so we have to keep the AV delay shorter. But it should not be very short, because we have to allow optimal AV filling also. So we have to optimize it with echo and program the AV delay accordingly in CRT. But in pacemaker, we have to program AV delay a bit longer if AV conduction is good. This is atrial escape interval. This VA interval, that is less of value, but what it is, low rate interval minus AV interval, it is VA interval. It is the longest period that may elapse after a ventricular event before the atrium must be paced in absence of atrial activity. So this is initiated by a paced or sensed ventricular event to the next atrial event. As we can see here, this from the starting of a ventricular pacing to the next atrial pacing event, it is VA interval. So there are two terms which is commonly confused: what is upper sensor rate and upper tracking rate. So there are first is sensor rate. It is the uppermost rate which is decided by the sensor of the pacemaker according to the body needs. Suppose a patient is walking, and then the rate will increase, and if running, then it will increase more. So according to the body needs, sensor will sense the sensor of the pacemaker will sense and decide the rate. So it is usually programmed higher in in young patients and physically active patient. So this is as in this case we can program it around 120. Yes, upper sensing rate is around 120, but in young patient we have to program around 150. What is upper tracking rate? It is the maximum rate the ventricle can be paced in response to sensed atrial event. So upper sensor rate is in response to sensor of the pacemaker. Upper tracking rate is in response to sensed atrial event. So it prevents rapid ventricular pacing rate in response to rapid atrial rates. So it is also usually kept around 120 or 130. But in physically active patient, we have to keep this also higher. Refractory periods, there is ventricular refractory period and post-ventricular atrial refractory period that is initiated by sensed or paced ventricular events. VRP is intended to prevent self-inhibition, like such as sensing of T waves, because once the ventricular pacing starts, there will be T waves and which can be sensed, and there will be pacing inhibition. So and PVAP, that is post-ventricular atrial refractory period, is intended to prevent sensing of the retrograde P wave. I'll discuss this. So this is atrial pace event. After that, AV delay will be there. Then ventricular pace event. After that, ventricular refractory period is there, and post-ventricular atrial refractory period is there. So this is in clinical scenario, this is more useful. Post-ventricular atrial refractory period, that is PVAP, is initiated by a ventricular event. It can be sensed or paced. During this time, atrial activity can be sensed, but it will not be tracked because atrial channel will be refractory. PVAP is programmable. Usually it is programmed as 250 to 300. What are the benefits? It prevents atrial channel from responding to premature atrial contraction and retrograde P waves, and can be programmed to minimize the risk of pacemaker-mediated tachycardia. I usually also see retrograde VA conduction during the pacemaker implant. So if patient is having robust retrograde VA conduction, then we should program PVAP higher. So PVAP and post-ventricular atrial blankening. During post-ventricular atrial blankening, pacemaker will not see any signals. So in PVAP, pacemaker will sense the atrium but will not track it. But in post-ventricular atrial blankening, there will not be any sensing of the atrial channel. So this is usually programmed to prevent crosstalk. I discuss. So as we can see, there is atrial pacing followed by ventricular pacing. Then there is blankening period. This one. And after and in continuation of that there will be PVAP. So if any activity here that will not be sensed by the pacemaker, after that it will be sensed but will not be tracked. So blankening is the first portion of refractory period. It is after atrial pacing as well as after ventricular pacing also. For after atrial pacing there will be post-atrial ventricular blankening, because atrial impulse can be sensed into the ventricle channel, the pacing spike, and that can lead to pacing inhibition. So there is blankening after the atrial pacing for ventricular, and there will be post-ventricular atrial blankening similarly to prevent crosstalk. Then one more term, that is total atrial refractory period, TARP. It is the timing cycle on the atrial channel during which the pacemaker responds to incoming signal. TRP consists of AV delay plus PVAP. It is directly not programmable, but we can decrease or increase AV delay or PVAP and then program the TARP. This is important for controlling upper rate behavior, especially in young patient and physically active patients. So TRP is sum of, as I discussed, AV interval and PVAP. As we can see here, it will sense event, then AV delay, sense AV delay, and then PVAP. So sum of this is TARP. Here TRP is 500 millisecond. So upper rate pacemaker can go is 120 millisecond with this setting. Suppose if we want 150, then we have to decrease one of these. So this is commonly asked in exam also. What is pacemaker when Quebec? When there is intrinsic atrial rate which lies between the upper tracking rate and TARP rate, then there will be pacemaker when Quebec. I'll show in the figure. So this is TARP, sense AV interval, and PVAP. Suppose atrial sense event is just after TARP, then it will be sensed and tracked with the prolonged PR because it has to complete the cycle of TARP. So there will be prolongation of sensitive interval and then P wave will start. If next P wave falls in the TARP, then it will get blocked. So if atrial sense event is just outside the TARP, it will get tracked, although with long PR, and ventricular pacing will be there. And when the next beat comes into the TARP, then it will get blocked. So as we can see here, there is atrial sense event, ventricular pacing, and then this atrial signal is in refractory period, so it will not get tracked. This is the implant which we have done day before yesterday. Here also pacemaker when back is there, atrial sensing, and then one beat drop, and then again a sense weak pace is started, and similarly it follows. So what is the treatment for this? We usually give beta blockers, or if atrial arrhythmia is there, we have to treat that. If intrinsic atrial rate exceeds the TARP rate, then every other event falls into the TRP and patient develops suddenly 2:1 AV block. So this is also one of the reason of exertional syncope after the pacemaker implantation. So as we can see, there is first atrial event A sense, and then the second event falls into the TARP, which will not be tracked, and there will be no pacing. And again, the next beat will be sensed and pacing. And similarly, it happens every alternate beat, and patient will have 2:1 AV block. So here we can see there is 2:1 AV block. Every alternate atrial signal is in refractory period. So 1:1 tracking agar when patient is having atrial rate below the upper tracking limit. If it is above the upper tracking limit but below the TRP, then there will be one back. If it is above the atrial rate above the TRP rate, then there will be 2:1 AV block. So we have to program it accordingly to the patient's need and patient physical activity status. Thank you.
Thank you, Dr. Raju. That was a very nice and precise presentation. I request every postgraduate and fellow not to store this topic and keep revising it, because it will be very confusing initially. So if you keep on revising, you'll get familiarized with it. And one more thing, Dr. Raju, just for completion's sake, I request you regarding ventricular safety pacing also. Maybe that is the only thing I think you missed in it regarding the intervals. If you can just brief regarding that.
So, ventricular safety pacing is when the event is sensed during the AV interval, like atrial activity or any other activity is sensed during the just after the blankening period. The pacemaker will give pacing spike after just to prevent
the crosstalk. Yeah. So to prevent ventricular instead of inhibition of the ventricular pacing, it will have some window where there will be a triggering of the ventricular activity, ventricular pacing. That's the ventricular safety pacing. Probably it is set at 110 milliseconds. Rest of the things I think you have covered very nicely. Thank you.
Thank you, sir.
Shall we move to the next topic?
Yes.
Uh,
Yeah,
Hello?
Dr. Usnish. Yeah. So Dr. Usnish Adhikari is a consultant electrophysiologist at the Kaveri Hospital, Chennai. So, yes, Dr. Usnish, we had one excellent talk go by. Dr. Rajiv's talk on dual chamber pacing cycles, a very important one. And again, the next talk, please introduce the speaker and the importance of the next talk in the context of people who are coming out of their training programs. I think it is a very important talk.
So I would like to invite Professor Abhilash SP, who is has been my teacher at Sri Chitra Institute, for his talk on preventing pacemaker infections. So, sir, you can please proceed. It's a very important topic for most of the cardiologists and electrophysiologists as well.
Yeah, good morning. Thank you, Snish. So happy to see you being in this chairperson's position, and Dr. Chandramoli. And thanks, Deep, for this opportunity. Shall I share my slides straightly?
Yes, yes.
Is it visible?
Yes, sir, it is visible.
Yeah. Thanks, Snish. Dr. Deep actually asked me to present on avoiding pacemaker infections. Actually, he gave one more addition to the title, that is the best practices. I personally do not believe there will be a single best practice done by a single person or a single hospital. There are many good practices. Any practice which prevents infection is a good practice, of course. I am telling this, I don't want to claim what I am going to present as the best practice, because we are a bit aggressive with our avoiding pacemaker infection protocols. We have a very low infection rate with respect to pacemakers, hardly maybe one case in a year or even less. But we do get at least say one or two cases in a month referred to us with the infected pacemaker. We have a hell time with these pacemakers. You know how difficult it's to manage the pacemaker when it's infected. The lead explantation, dependent patient requires some temporary pacing, semi-permanent pacing, reimplantation, cost, a lot of things. So I think we are a bit aggressive. I'll come to that slide later, where it may not follow any our standard guideline. I told the reason why we are so. We'll go to the topic proper without prolonging my introduction. We don't want to see a patient like this, no. After getting the pacemaker done, maybe 2 or 3 months later, comes back with fever or something like this, swelling at the pacemaker site. And you don't want to, definitely you don't want to aspirate something like this from the pacemaker we have done or someone else has done. And we don't want to see this as well. Repeated infections, repeated dressings, then finally the pacemaker comes out and then comes to us. It's a difficult situation. So it's very difficult, tough to manage pacemaker infections, but that is not the topic. Our stress is going to be how to prevent it. And of course, it starts with the patient. As like any other procedure or as in anything in medicine, it starts with the patient. And we need to get the patient details. We need to immediately stratify based on the history, whether we are going to do an emergency procedure or an elective procedure. Emergency procedure, I think the rest of my discussion in this slide does not matter, because it's going to be an emergency, and whatever, even if the patient has a fever or even if the patient is on some antiplatelets, we are going to do it. So, but elective procedure, don't do it. Say pacemaker for a sick sinus syndrome, an ICD or a CRT. Don't take up the patient when the patient has fever. Find out the reason for the fever, treat it, and then take it. Sepsis anywhere, of course, please don't take it. We know we are in a busy practicing schedule. Some UTI we may ignore, some cough we may ignore, but that's not good practice. Even if it is rare, the treating a infected pacemaker is a hell. So don't do it unless, as I told, the original procedure was an emergency. Don't look for this anywhere in the skin, especially near your incision point or anywhere, even in the lower limb. Treat it. If it is a sick sinus, what is a hurry? Treat this pharyngeal or any this cutaneous. This can be a good focus for the staphylococcus. We all know that. And look at the basic investigations we have done. A WBC count of 41,000. Please don't take the patient. Here it is eosinophil, but find out the reason for it. We don't want a leukemia to be diagnosed after pacemaker. So get the evaluation done unless it is an emergency. We need to get a good medical history. You may be wondering why antiplatelet history is important in preventing pacemaker infections. The thing is that a hematoma at the site is a very predisposing condition for a pacemaker infection. So patient on multiple antiplatelets, our scheme is stop antiplatelets unless it is mandatory. Wait for 5 days for an elective case. Or if it's a post-ended patients, they want to be on an antiplatelet for sure. We try to be on single antiplatelet. We don't want to manage a hematoma later. If you want hard to say hematoma develops, if you have to open the wound, your infection rates actually goes much higher, from 1% to almost 6%. That is 600 times. Then again, anticoagulants, you can, the same logic applies here. If possible, stop it. Otherwise, continue at a low INR of say 1.8 to 2 and do the procedure with extensive use of cautery. Or if you want to how to stop it, reintroduce the heparin without bolus. Then this also will stratify the patient, steroids and immunosuppressants. You need to worry much more about a peri-procedure infection. It's not a contraindication for doing pacemaker, but you can tell to the relatives that there is a risk of increased infection. And you may have to give antibiotic a bit aggressively than the guidelines suggest. Diabetes, yes. CKD, some of the antibiotic like amikacin or gentamicin or vancomycin, if at all we want to give to cover the high risk, that will be difficult when the patient has a CKD. So look for these clinical parameters in a patient with the, of course, with the aim to prevent infection. So what we will do after this risk stratification is done for the patient, from the ward or ICU where the patient is, we start preventing the infection. We have given an instruction to our nurses to clean the area after the the normal shaving preparation is done. We actually use the soap solution or the 7.5% betadine, whatever form it is available, to clean the upper chest. We asked to we have given instruction to start scrubbing from our anticipated incision site on either side, upper chest, extending up to axilla. We ask them to do a one cleaning with 7.5 betadine while they are at the ward or an ICU itself. Then we again ask them to put 2 cannulas, one of course on the right hand, one on the left hand. One is for, you can, on the left is specifically done for venogram, which we do almost in all patients. Right for any other medications, antibiotic or emergency drugs. But we ensure that after the procedure is done, we remove the IV cannula on the side of implantation. There is no data for any of this, but that is our practice. Then we give antibiotic. You know, the guidelines say you say narrow spectrum cefazolin or similar antibiotic as prophylaxis before shifting to our cath lab. But in practice, we use much more. I will come to it because in the next slide, we give cefuroxime 50 to 100 milligram per kg, and we do give amikacin if the renal function is good or the patient is not elderly. In these 2 situations, we substitute with ciprofloxacin. This is not based on evidence, not based on any guideline, but we do manage the infected pacemakers every day, and we have become paranoid about pacemaker infections. So we are okay to overtreat a bit with this regimen prior to shifting the patient. The patient may get 1 or 2 doses also before discharge after this. Then they get the oral antibiotic. But I don't want to bring a controversy here. The international guideline is to give a narrow spectrum antibiotic followed by oral cephalexin or similar for 3 to 5 days. What we practice is we give cefuroxime, amikacin or ciprofloxacin, depending on how friendly the kidney is. Then we continue it with cefixime, amoxiclav or ciprofloxacin oral. And off-label, we do one more thing. We give vancomycin 500 locally just before closing the wound. That is, it's off-label. Vancomycin is not approved for this use, but we do use, and this is our practice for the last 10 to 15 years. It's not something we started recently. And our infection rates, believe us, it is very low, very low. So probably that is one reason we don't find the reason to change. Then this is, the armamentarium for a pacemaker. We have numbered it from 1 to 29. Some 29 gadgets are there. So all the people who handle this should be aware of the sterile precautions. After the patient is reaching the our cath lab from ICU ward, everyone. The thing is that I want to show this picture because it's not us alone who is involved in this pacemaker prevention. We need to ensure that a proper autoclave system is there in our hospital. We need to teach our techs how to clean it after every pacemaker and then send for autoclave. We don't dispose every device after, unlike some Western countries. So you need to teach them. So we need to convey this to our sterilization team, how to do it meticulously, how to pack it meticulously, and bring it to our pacemaker table. Then it starts with scrubbing. Some people, some guidelines, the surgical, how to scrub and all. I'm not going to elaborate it, how to do it from fingers, interdigital space, likewise. But we ensure that you need sufficient contact time with the betadine or whatever solution you are using. You need to initially wash it with soap up to elbow. Then we use a betadine up to elbow. And we use one more betadine, but not reaching up to elbow because we may accidentally touch unsterile regions. So the second betadine pot will be just over the gloved surfaces. So one soap up to elbow, one betadine up to elbow, and one up to the gloved region. But we please ensure that sufficient contact time. Betadine is a contact disinfectant. So we need to give enough contact time to this procedure. Please don't cut short time spent for this. Ensure that 3 scrubs are done. Don't forget your scrub nurse also. She is going to assist. She is going to handle all the instruments. So ensure if she is new, teach her how to do it. Don't assume that she will be doing it. When we observe, many of the time we do see that a single scrub is done. Maybe the scrub nurse has just come from a coronary lab. Then they may not be following much. I'm not telling that coronary lab you need to do lesser, but coronary lab probably most people do only a soap and maybe one betadine. But we want at least sufficient contact time with 2 to 3 scrubbing prior to a pacemaker. Then don't do this. This is a picture from our own lab. You are keeping all your gloves just below the trolley, and don't assume that these edges of the sheets, these plastics are sterile, because every patient who is going to get a glove is going to touch here. But that is our practice. We have a very congested lab. So we do keep it like this even now. But instead, what we do is actually we take a different trolley for getting the gowning and gloving done. But be like wary of these areas. These are going to be unsterile. Then I know I may sound too basic, but when I observe when the new resident come, we assume that they know how to put they know how to put a glove. But when you observe that, no, they are doing it, but certain things we need to take precaution here. You're going, please pardon me if I sound too basic for the seniors here. This is primarily targeting the residents in training. So you put the first glove, then you know that you are not allowed to touch the glove with the bare hand at any point. So don't bring this hand to pull the proximal part of this glove up. So just leave it at. That is step 1. Until now, you know that you have not touched this glove with bare hand. Then put the second glove and pull it up with your gloved right hand. Now use the left hand to pull it up. Otherwise, we can potentially touch with our bare hand one of the glove. So this is not for pacemaker alone, for any sterile technique. Follow this technique. This is how we are supposed to wear a glove. Don't touch with the bare hand. Put the second one. Then after putting the second one, you complete the gloving. Then it's a tendency to put your, when you want to turn around and complete the gowning, you keep it somewhere under the surface of your table, somewhere there, but don't do it. You can potentially become unsterile while you turn around. You see how narrow the space is there to turn around. You can potentially become unsterile. So give it to one end of this gown. You give it to one third person who has gowned it, who's already gowned. Or in some centers, actually, they help to put even the first glove. Then turn around. Then after this, the second glove is done. So the order is first glove is first done in the way which we mentioned. Then after that, turn around so that you, while doing this maneuver, if you touch accidentally, the second glove will cover it. So do the second glove after this turning around maneuver is done. Then preparing the local site. We do use betadine commonly. As already told, the betadine requires, it's a contact disinfectant and requires 2 to 3 minutes of contact time. So if you're not patient enough, what we do suggest is you wipe it 3 to 5 times. Many of us won't be that patient enough with one coat and wait for 3 to 5 minutes, but this will not dry. So what we can do is at least you do 3 or 4 times so that we spend more time on it. It's nothing like doing it twice or thrice makes a difference, but it makes us spend more time on scrubbing this. So from the area of your incision, go centripetally and don't come back to the original space again. Go, then wipe till the axilla. If you are using chlorhexidine, you apply only one paint. Usually for a pacemaker, you keep the arm adducted. So you'll be wiping here and touching the axilla only or a part of it. This is kept like this because this was for a subcutaneous ICD. The difference in chlorhexidine is you wait till it gets dries off. So again, the principle is allow enough time to, enough contact time. Then if you're using say cloths or if you're using the kit, you need to follow certain orders in which you are going to put it. For the cloth, if you're using in your lab has this, you put this, the proximal one as first, this one as the second, this one as the third, while catching at the reverse side of the cloth. Otherwise, we may accidentally go and touch the skin. And then finally, you put the fourth one on the opposite side. Then you can cover the IE cover. This one, you don't have to worry any of this. But if you're using a cloth, you follow a particular sequence in which you can minimize the risk of infection. And some centers actually remove the glove after doing the skin preparation. That's also a good practice, even though we don't routinely do it. But that's a good practice, I think, which can be followed. Then once you start the incision, before that you are going to give the local. So try to give local from a single skin puncture site. Don't take it out, give another puncture here, take it out, another puncture here. No, you use rather than having multiple skin openings, you do it from one point and then move around the needle. That's a good practice. Then the pacemaker is done. And as you know, most of the prevention is done prior to the pacemaker implantation. And this could be an option if the patient is affordable after the implantation, before closing the wound. This is actually the Medtronic Tyrex, which releases actually a few antibiotics. But we are not routinely doing it because we don't have enough data. That's one thing. Second thing is it's very expensive. It costs upwards of 70,000 in India, which is more than a single chamber pacemaker. So we are not using it routinely. It contains rifampicin and minocycline, but some centers in the West are using it. We hardly use it, and we don't see. It also says that you don't have to use it routinely. We have very low infection rate even without using this. Then once the local vancomycin and suture, everything is done, we typically, after the subcutaneous suture, we typically apply this steroid strip over it. And then we cover it with a tegaderm with a gauze. This is how the wound will look like at the end of the suturing. I'm showing this because we are going to call the patient after 7 to 10 days. At this point, we found that when you are going to remove both the tegaderm as well as the steroid strip, if the patient has come within say 7 or 8 days, the edges may not be healed. So at this point, please don't remove the steroid strip. You can remove the tegaderm at 7 or 8th day. Or if you are calling the patient after say 8 to 12 days, probably if the edges are healed, you can remove the steroid strip. Otherwise, we have found that the premature removal of the steroid strip is a reason for wound edge infections. I will show a few slides for that. So now our practice is we call the patient after 7 or 8 days. We remove the tegaderm with the gauze. Then until then, we ask the patient not to wet this region. Then we ask the patient, you can take normal bath. In another 2-3 days, this will fall off. So we don't routinely remove steroid strip nowadays. This is one particular case where when the steri-strip is removed, the edges are not fully healed. But the good thing is, that pocket looks healthy, remaining wound looks healthy. He had no features of systemic sepsis. So what we just did is we put one suture there, and another week later it healed. But this is unnecessary. Don't remove the steri-strip at your first visit. Maybe another 3-4 days later, if you had removed, this wouldn't have happened. This also can even see any infection near the newly implanted device is a risk for pocket infection. So handle even this small infections with care. You need to approximate it. You need to dress it centripetally from center to periphery. Keep it daily dressing. Give an oral antibiotic. So treat any local infection aggressively. This is how we usually try to prevent infections. And this is technically not infection related. You can see it is dry. It just may be infected. Unlike the previous picture, everything is fine. The device is not seen. Wound is clean. Here you can see the PG is coming out. This is probably it's an erosion. Usually that happens on the lateral side with some secondary infection. Here, anyway, we can't attempt this conservative management. We will have to explain this. Any pocket infection, we need to explant. Erosions like this, we need to explant and treat it. And this is what I was talking about. If the patient develops a hematoma, I told you the chance of pacemaker infection is 1%. But if you have hematoma, which requires evacuation, or if you decide to put a needle into it, the infection risk is 600 times. That's 6%. Don't do it. This tests your suture integrity, that I agree, but don't open it unless there is a very massive ones. Mild and moderate hematoma, don't open it. Just conservatively manage. Don't try to open this. If at all it comes out, it opens out spontaneously. You do regular dressing from starting from center to periphery. Keep this area healthy and give antibiotics. Don't allow a secondary infection to develop in a hematoma. So the management of hematoma is don't open it. The risk of infection is going to be very high. And this is, see, I just want to begin. We commonly come across these things. You can see the wound looks good, but you see the redness around it. This is not an infected wound. This is the allergic reaction to the plastic, the Tegaderm. A particular batch of or a manufacturer of that Tegaderm or similar had this issue with us. You can see another one, a blub there. We were worried that it could be a boil there, but no, after removing the plastic, it settles quickly. So this could be just allergic reactions. You look at the original wound, you look at the pocket, rest all looks fine. You need not aggressively manage this. This is another, again, reaction to the Tegaderm which we apply. So these are not infections. Just distinguish this from the true wound infection and true pocket infection. Again, they are different. Local wound infection, you can treat conservatively. But once it goes to the pocket, don't try to manage it conservatively. Most of the time, this will end up in extraction. If you don't do it, after a few months later, we will have to do it or someone else will have to do it. At that time, probably we'll have to manage an endocarditis as well. And we started with the patient. I'm going to finish it off with the patient also. A happy patient. See, the trauma of a pacemaker infection is going to be seen or experienced. Please prevent it. Thank you.
Thank you very much, sir. It was a great presentation with great illustrations also. So I had one question, sir, like what is the suture, though I've been the part of this also, what is your suture steps or what are the sutures that we are using? Because it varies like what sutures we are using and how many layers we are using in different hospitals. And one more question similar was there, what about staples for closure?
We don't use staples. And again, I don't think I can advocate that this is the suture to be done or this is the way, because every center has different practice. But what we do is we initially, once the pacemaker is in place, I already told you we use some vancomycin. In the early days, maybe 10 years back, we were putting some gentamicin also off label, but it was sticky and gentamicin has the renal issue and we changed over to vancomycin locally. After that is done, we do a first step pocket isolation suture, pushing the PG away from the original incision site with a 2-0 non-absorbable suture, Vicryl or similar. Then after that, we routinely put 2 more layers. One is the pocket isolation switcher. After that, 2 more layers. One, depending on our preference, it can be 2 interrupted layer or 2 continuous layer to save some time, or 1 interrupted or 1 continuous. I prefer continuous because it gives significant strength and it's faster. This interrupted switches can give away fast, much easily. So after the initial pocket isolation switcher, I routinely put 2 layers of continuous, means running continuous, one go to one end and come back to the original end. That is my preference, but it can be anything. That is again done with a 2-0 Vicryl, or that's a non-absorbable switcher. Then after that, we complete it with a 3-0. 3-0. Previous ones were 2-0. 3-0 subcuticular switcher to complete the subcuticular incisions. The permanent switches or ethibond or similar were used for the permanent structures like leads and the PG previously. I'm not telling about that. All our skin switches are with 2-0 Vicryl or similar, and the final subcuticular is 3-0. 3-0 absorbable switcher. Then we complete it with Steristrip. Steristrip also gives a good strength to the wound.
Another question was there, when should we first dress the pacemaker after the procedure?
The thing is that we are using all these are absorbable. In our practice, we use 2-0 Vicryl for the initial switches and complete it with subcuticular. So we have no switcher popping out of the wound. You can see the pictures I was showing you. We just cover with Steristrip and then the gauze with the Tegaderm. I know that some centers use silk. Silk is being non-absorbable. You have to remove it after say 5 to 7 days. You need to keep the patient with maybe a very alternate day dressing, but we don't do that at all. We don't open the wound because we don't use any such material, any non-absorbable suture for our skin sutures in our pacemakers. We keep it closed and ask to come after 7 to 10 days. We remove the Tegaderm, we remove the gauze to see the integrity of the Steristrip and edges. If the edges are clean, maybe the patient has come after 10-12 days, you can remove the Steristrip. Otherwise, we don't touch the Steristrip. We keep it for another 3-4 days. Those people who do with a silk, I think their practice is to dress it every alternate day. They keep the patient for say 4 to 6 days. But I think this is much easier. You use the absorbable suture. You don't have to open it. Many of the time, the infection you get it when you do the dressing. You can, if you don't do it, let's say, like meticulously on that day, you're in a hurry, you can get secondary infection at that point. Here, you are eliminating all such risk. Use only the absorbable sutures.
So there are some 2 more questions. One is how long do we give post procedure antibiotics? Pre is only 1 dose, I think. And post procedure, how long do we give? And when will you ask the patient to bath? I think that already we have told, like after we remove that. You have told that after we remove the Tegaderm, then we ask them to bath. How long post procedure antibiotics? That is one question.
To that question, it's first I will give a political answer, which is the guideline. You give a narrow spectrum antibiotic initially, 1 dose or maximum 2 dose, then follow it up with an oral, say cephalexin, 500 milligram QID for 3 to 5 days. I told you, controversial. We follow it slightly differently. We give 2 antibiotics, cefuroxime and either amikacin or ciprofloxacin, 1 dose or 2 dose. After that, we give cefixime, and if we couldn't give say amikacin, we add ciprofloxacin also another 3 to 5 days. This is meticulously done if the patient has diabetes, CKD, high risk for infection. If it is an emergency procedure, yes. If it is not, maybe cefuroxime alone for 3 to 5 days. Cefixime, not cefuroxime. Cefuroxime is parenteral. Cefixime 3 to 5 days, or augment in 3 to 5 days. But in practice, let me be frank, our patients get injection at least 2 or 3 doses while they are in the hospital. And then they get 5 days of cefixime or an augmentin.
Thank you, sir. 2 more questions are there. I think it has already been answered. what are the pre-discharge advices? Pre-discharge advices means immobilization and all. I think they're asking for that.
No,
And
probably
what
that
do
is
you
the
use for Savlon or betadine for pre-preparation? So I think
See,
anyone yes, sir.
yeah, we use betadine. I don't think Savlon should be an issue, but we don't use. But their routine, most of the centers where I have worked use either betadine or chlorhexidine. I've shown the picture of chlorhexidine also. Savlon I have not seen somebody using, but I don't think if somebody is using it routinely, then it not change it. Savlon is acceptable antibiotic, but we use betadine. Regarding the other question, immobilization and all, probably that is our topic, prevention of pacemaker infections. But still, I would try to answer. Immobilization, we do it for a day. Then we don't keep it immobilized. So if you are doing it today, tomorrow we are planning to discharge. At that time, we release it, the sling. Then we don't put any routine sling after discharge, but we do tell the patient that don't move the arms for excessively for the next 4 weeks, especially above the shoulder height. And we do tell them that don't keep it totally stationary because they can develop frozen shoulder. So we tell you can move limited movements, but don't do it above the shoulder. That is for 4 to 6 weeks. We encourage wearing, I'll say, weights on the arm again after 4 to 6 weeks.
Thank you very much, sir. I think a lot of comments are there regarding the sutures and all. I think different places and institute, they have got some different protocols.
Yes,
Yeah.
sure.
So
Any
that will be
method which is
variable.
working
Yeah.
for the center is very much acceptable.
Yes.
Follow your even antibiotic also, depending on your infectious disease expert's opinion. Follow the regimens which suits you. Don't follow what I presented, but this is our practice for the more than 10-15 years.
Very nice, Dr. Abhilash. Thank you so much. It was so practical teaching for the students, a very important topic. Sir, Dr. Ajay Nayak, sir, President of the Indian Heart Rhythm Society. Thanks, sir. It's all going well, all the sessions. This was the 5th session of the training program this year. You have a few comments to make on this particular topic as well as the whole program and the upcoming sessions, sir.
Yeah, thank you, Deep. This was an excellent session and fantastic lecture by Dr. Abhilash. Very practical things. Very good. All the series is going on well, and I hope all the DM DNB students are taking full advantage of this. Please let your friends know it also. In India, if you are going to practice either cardiology or EP, you will be taking care of not only adult patients, but especially if you are at the periphery or smaller towns, you will be taking care of patients from day 1 to 100 years of age. So we are going to have a pediatric oriented session next month, that is 8th of June, in collaboration with the pediatric CSI. So it will be pediatric arrhythmias and taking care of pediatric EP issues, devices issues, along with the pediatric CSI. I think it's going to be an exciting session. Please let your colleagues know and do join. Great show, Dr. Deep. You're doing this really well.
Thank you, sir. All with your guidance and all the seniors' guidance, all going on well. Thank you. Wish you all a great Sunday. Enjoy your Sunday, and we will meet again next month.
Thanks, Deep.
Jai Hind.
Yes, sir. Jai Hind, sir.